everyone. Welcome to the six. But I know, no, your math is not. I know the math isn't mathing this afternoon. There is only four of us. Allison, unfortunately, had something last minute. Pat is on vacation, but we have Gautam Kumar with Milu Health with us today, who is our sixth, but really our fourth, if anyone wants to get technical on the math here. And what we're going to talk about today, let me back up. I'm a newbie to the whole podcast thing, so let me step back. I'm Robin Flaherty with Benefit Link in not sunny, but damp and rainy Rochester, New York. But we have our claim to fame Monday. We are in the path of totality. So we are a handful of cities that are in the path of totality on Monday for the eclipse. So that and maybe one or two other things is all we have, but it is a great place to live. So again, from Rochester, New York, we have Liz Antea from sunny Florida. Liz, don't tell us what.
I'm so sorry, but it's a beautiful day today. It was super rainy all day yesterday, but today is gorgeous. Liz Antea with Stoll & Associates Insurance. We are a partner now of Higginbotham. So I'm happy to be here. Thank you.
Okay, Christine. All right. And Christine Schreier with K2 Strategic. Christine, remind me where you live.
I'm in Chicago right now.
Right.
So also in the path of totality. Yes. And where do I was just actually Googling this yesterday, where I can go to get my eye gear to be sure that I'm protected and can look on Monday. And I read that Warby Parker is actually
out
of their stores for free. Yeah. So I'm going to walk over to a Warby Parker physical store this weekend, and hopefully they still have some in stock.
Right. You might want to call. Well, I have to go to Tampa, but I saw that too. So yeah, definitely wear your eye gear, right?
And also a quick PSA. Apparently, you have to make sure it's ISO certified because not all eye gear is created the same. And my understanding is you can really, is it your retina? You can burn it and it doesn't come back. So just be really careful.
Yeah, they said don't order it on Amazon. Or at least look for that certification before you order any on Amazon.
Okay, I did order mine on Amazon.
Or like Temu, TEMO, that shopping site.
Okay.
Yeah.
Perfect. All right. Thank you. All right. Well, and our very special guest, Gautam Kumar with Milu Health. I just want to real quick, I cannot possibly explain Milu better than you, Gautam, but I would like to just make a quick comment that we put Milu Health in a client. And so far, and tell me if this is right, you have saved an employee about $6,000 on a prescription. One prescription, one employee. Wow, that's pretty powerful. So we can't wait to hear about what is Milu Health. And again, our topic is healthcare interoperability, which is also a very big topic. I personally think the success and failure of every cost containment strategy really hinges on getting this right, the interoperability. It makes complete sense why we need it. We're going to talk about why we need it, why it's important, and what is in it for the employee and the employer, aka the healthcare consumer collectively. And so from there, I'm gonna volley it over to you, Gautam, if you could let us know a little bit about yourself and how you, your background and how you started Milu Health. I know you're a co-founder, and then we'll jump into some questions.
Sounds great. Thanks so much, Robin, Liz, and Christine, for having me. Excited to be here for the 6/4, I guess. I am calling in from New York City. Where I think we had some of the rain that we may have sent over to you, Robin.
Yeah, I know. It's up north. I know.
Sorry for that.
It's okay.
But like Robin mentioned, I'm one of the co-founders of Milu Health. We are a digital health company, and we're really here focused on trying to figure out how we can reduce the cost of care for Americans. And the way that we're doing that is by working with employers who, as the three of you know, have such an incredibly large role to play in the U.S. healthcare system, and really have a lot of agency, a lot of ability, a lot of power, and a lot of initiative to be agents of change to try to make sure their employees get better healthcare and also get that healthcare more affordably. So what we do at Milu is when we work with employers, we have our own product that we deploy to employees. And when employees use our product, they can connect what's called their electronic health record, their EHR. So this is like their doctor notes, the labs, all that stuff into our system. And we have software and a team of nurses that then will help go through some of that data and work with patients to find ways that patients can get better healthcare and also more affordable healthcare. And it takes the flavor in a few different ways, but like one is going to be, for instance, if we see a patient struggling to get an appointment at an imaging center for, like, let's say an MRI, we can find for that patient, we can see that appointment get recorded in the EHR. We can say to the patient that, hey, we found some great local in-network MRI centers that have availability tomorrow or the day after, and we can help the patient coordinate the scheduling to make sure they actually get to that center. We also help out with prescriptions. It can be so complicated to figure out where you can get a prescription more affordably. So, we have all of our data and on all of our assets on our side to try to figure out that, hey, we see this new prescription is written up for a patient, which is the pharmacy where the patient get it more affordably, and tell the patient that, hey, instead of going from pharmacy A, instead of going to, like, let's say a Walgreens, maybe you want to go to a Costco or something like that, or that there's another place where they can get that medication more affordably. And the last thing is helping out with specialists as well. Such a complicated process. Often, when patients are seeing specialists, they've got a challenging health consideration. If we see that a patient requires help from a specialist, we'll try to support that process and say that, hey, we will provide you a list of the doctors in your area who have performed the most of those kinds of procedures in your area, who are in network and again have availability, and again support them through the whole process. It's a few of the things that we do at Milu. We've been excited to work with your client Robin and trying to get some more savings as well for patients. And we're big believers, as you hinted, into interoperability and how important that is as really a gateway for opening up a lot of innovation, a lot of opportunities for patients and employers.
Right. Yeah. Well, thank you. And it's funny. We should really quickly start with just a brief definition of what is healthcare interoperability, right? I mean, I think I think one of the mistakes I know I make all the time is that I've been doing this for 26 years and I'll talk. And I know that, I had a client once say to me, I was all excited, delivered some information, and I'll never forget it. He said to me, he goes, listen, I get that this is your thing and you're super excited about it, but you know what? I just really want you to tell me what to do. I trust you and I'll do it, So for those though who have joined us today, we're thinking you are of the crowd that does like some of the details. So basically just a quick definition of interoperability in healthcare refers to timely and secure access, integration, and use of electronic health data so that it can be used to optimize health outcomes for individuals in populations. So there's really an overarching definition of it, right? And it has significant financial impact for employees and employers, right? Employees have engagement and empowerment of their healthcare, which will lead to management. And then, of course, employee cost management is going to flow down to that ultimate ledger that the employer is keeping for the health plan, if you will. And again, it's a whole other conversation how the employer ever got involved. I just listened to an employer tell me yesterday, actually, that they wish they weren't involved. How come I have to be involved? This is what I do over here. I don't want to be involved. And I said to him, like Dave Chase tells every employer, right? Well, whether you like it or not, you are in the business of healthcare, because depending on your industry, it is your second or third largest expense on the income statement. It's either right under payroll or it's right under your cost of goods sold. So with that, you are, unfortunately, employers are. And again, it's a whole other conversation about how the tax law came in and really put the employer in the position of being involved, right? And we'll just leave that at a very 100,000-foot level. So Gautam, tell us, can you share your journey and experiences in healthcare operability? I know you've mentioned it just a minute ago in the context of Milu Health and what Milu Health brings to the table for the employee and ultimately the employer. But, how did you get where you are right now? What was your journey? And, give us some information on that.
For sure. So a bit on my personal journey, how I got to Milu. So I, before starting Milu with my co-founder and I actually worked together at a previous company that was in genomic sequencing, specifically for oncology patients. And I think that was that was where we first started dealing or learning about a lot of the problems in healthcare. And I think we just saw so much opportunity. That company was really interesting. It was trying to use clinical data and genomic data to try to figure out how you can push the envelope for new drug development for therapies and for diagnostics and make sure cancer patients get better treatment. A lot of cancer patients, we're still using a lot of drugs that were discovered maybe 50 years ago. Only the last 10, 15 years have you seen the new spate of therapies that come out that are really innovative and new and really sort of having a huge impact on patient outcome. Through that experience, though, in terms of how we then figured out and went into Milu, I think we saw that cancer was really one of the drivers and one of the larger drivers that was pushing up the cost of healthcare. And we would see from patients and loved ones of patients where they'd be like, I realize this drug is going to be amazing, but what is this going to mean for my family? What is if ultimately something bad happens and the drug doesn't work? Am I going to leave my patient? Am I going to leave my family with a lot of debt? And I think that's sort of where we were like, okay, we actually got to do something on the affordability of healthcare to make sure patients get better quality care. On interoperability, I think that the incredible thing to remember about interoperability is just that how new it kind of is. It really hasn't been around for that long. And I think that there's been a lot of changing regulations that have taken place. It goes back to the 2016 Cures Act with a lot of that has now actually gone into effect only in the last few years that makes electronic health record data, the patient data, much more widely available, which we can get into. That's enabled companies like us to actually come in and take a look at that data and try to figure out how you can actually help patient care and support the care navigation.
Okay. And talk a minute about, because I'm sure that what is on everybody's mind is safety, security. How are we keeping everybody's data safe? Because I think that is going to be an imperative for people to get comfortable, to want to share, if you will, because that's really what has to happen here is everybody has to see what's in it for them and the greater good of this interoperability coming to be. But of course, it has to be done the right way. It has to be safe. It has to be secure.
I think one of the advantages of coming in from healthcare, starting this business with healthcare experience and having worked in health tech beforehand, is understanding what you actually need to have to secure the data securely. Like how you actually, what are the protocols, the security systems, all of that stuff and all that apparatus that you need to have. And for us, it was a very deliberate decision that from day one, we knew what we wanted to build with a very high threshold of patient privacy and security in mind. And so we invested a lot of effort and a lot of energy and a lot of engineering time to make sure we actually have that. So that materializes in ways that, from day one, we knew we wanted to be SOC 2 compliant. We wanted to make sure that we had highest security grades that you would expect of any kind of hospital or EHR system. We want to make sure that we were HIPAA compliant. We want to make sure that we were actually dealing with patient privacy in a way that was at the highest level. It makes sure that we want to make sure everything's encrypted to the highest form possible. So we really invested a lot there for us, and I think it was really helpful to have the experience from beforehand to understand what you need to build, just because the security systems for healthcare are so particular, and you build them at such a higher level of standard. And it was helpful to have the context to understand what was the journey and what does good really look like.
Okay, right. And so who else is trying to build an interoperable environment? Are you aware of anyone else that's trying to build this? I mean, I know there's a race for the new healthcare ecosystem, but I think the ecosystem and interoperability could be the same thing, but may not be the same thing.
I think you have a lot of players that are trying to support interoperability and trying to make it more available. I think the first users, honestly, are a lot of doctors, and I think they're trying to use it in their own practices. Like, it's kind of incredible where, if you were a patient even 10 years ago, I mean, let's just sort of even give a bit of history, right? Back in 2008, only 10% of hospitals actually had digitized health records. Everything else was paper and pen. And so you didn't have a way to actually store the data, let alone share it, okay? That was 10% of hospitals in 2008, right? And then you start to have some regulation that results in hospitals, the incentive when there's a stimulus package in 2009, that ultimately led for a lot of hospitals to actually digitize. There's a provision in the stimulus package that said if a doctor actually digitized, they would get up to $44,000. So any practice that had 2 or 3 or 4 doctors, you multiply by the number of physicians, that's how much you're eligible for. And then by the end of 2014, I think you ended up with about 95% of hospitals that actually had electronic health records. So in 2008 and 2014, you have that increase from 10% to 98%. So this whole idea of even having electronic digital health data in our ecosystem, it's only really existed for 10 years. And the first path was really making sure you had the digital health data. Then there's a whole other challenge of how do you make sure that hospital A shares health data with hospital B? And the main customer for that need was really doctors. And so those are the people who are really pushing and making sure there's sufficient interoperability. So you do have ways in which now doctors can query and say that, hey, I now have a new patient, I'm seeing Robin for the first time. Can I see where else Robin has gone in practice? Let me try to get data, not just from Rochester, but maybe from some other places where Robin has lived to try to get a comprehensive view. But those are sort of actually, it's kind of funny in that instance, the providers are sort of the early adopters there. Other innovations and other technology companies are trying to build on interoperability. You haven't really seen that much yet, just because it is sort of this kind of insanely, it is sort of this new thing that now exists in our health system.
So if I may, I'm going to reshare the story that I was telling you all before we started live. I've been navigating a care situation with a close family member who is in their 80s. It's one of my parents. And they were diagnosed with cancer a couple of months ago, and they are living in South Florida in a very affluent area in the winter. So they're in a high economic area, but the quality of healthcare there is low. The 2 health systems, the 2 hospitals don't have great scores based on, objective, a couple of different databases. Of course, I researched that as soon as I found that out. While his doctor there, the specialist does, the hospitals don't. So fast forward to, how the process has looked for him. He gets a diagnosis, and the way that the specialist handled it was to basically tell him that he really only had one treatment path, and over a 30-minute appointment said, here's your path, and we'll go ahead and get everything scheduled for you. So here's what your next 6 weeks look like. Here's what we need to do, the first 2 steps of that treatment process, and you're going to receive a phone call within the next 1 to 2 weeks with your scheduled appointments. So, right away, we're at one end of what I consider to be the interoperability path. And there was never any conversation about other options or second opinions or choice of situs for care or any of that stuff. And there's, of course, in Medicare and even Medicare supplements, which they have a fabulous supplement plan, there's no care navigation built into that. So your care navigation naturally becomes whatever that doctor tells you and however their staff actions on that. So we ended up, my family, getting some nurse concierge support, and ended up, going to Mayo Clinic in Rochester. So records had to be transferred. 2024, affluent hospital in South Florida, can't electronically send records. I hear that 3-letter word that still boggles me that I hear in 2024, which is fax, F-A-X. Like, who's still faxing? Healthcare is still faxing.
Now, wait a minute. What's interesting is fax has its own history on when, whoever bought the first fax machine, someone else had to have one in order for that technology to work, right? But
exactly. But even the scans, I literally had to go with them to the hospital to pick up a CD with scans to physically carry with us to the Mayo Clinic when we flew up there. So, this whole process, I told Robin this yesterday, I had never heard the term healthcare interoperability before. but I fully understand what it is. I just hadn't heard the term. And I've literally been living it the last couple of months, living what I view are the opportunities in healthcare interoperability from a patient, through a patient in a provider lens, watching how these providers can and cannot interact.
And I think, Christine, I think we probably all have a story, right? But mine actually originates from 2012. So Gautam, that was my question, because you had said it hasn't been around for very long yet. And I was like, well, is it really here? Like where? Because I haven't experienced it really myself. And I think it's just the patient and the family trying to advocate for the patient that has such frustration when it's not there, right? You can certainly feel the absence of it. But this was, like I said, back in 2012. So maybe it wasn't there. I don't know. You said 2014 when real adherence?
Well, so I mean, 2014 is when you start to have like now 95% of all hospitals actually have electronic health records. So in 2012, it may have been around like 70%, 65%. But healthcare, the funny thing about if you think about the phases of digital health data that has existed, right? So electronic health record data, you have the first phase, which is like, let's make sure that we're not using pen and paper. Let's have software, and doctors are putting in their notes into software that's now structured, and it's not the chicken scratch like we were talking about beforehand. It's actually structured data that you can actually now have as a text file. The problem was you have a bunch of different vendors that are providing different electronic health record systems to the hospitals. You have Epic, you have Athena, you have Cerner. And that's where now interoperability comes in, Liz, to your point, which is that only around 2012 did you start to have like some idea of a consistent data format that these EHR systems were to conform to. But even still, you didn't always have the case where hospitals really were sharing the data, because sometimes think about it. If I'm a hospital and I have a patient, I don't want you, Liz, to go to another hospital, right? And if I lock up all the data, you're staying with me. You're not going to go to another hospital because it's going to be such a pain to get it up to another hospital. And you're seeing that right now, Christine, like you were mentioning. So there's still some echoes of that, exactly. So sorry, go ahead.
Go ahead. No, go ahead. Please finish. Sorry.
But no, it was just that we're still living with a lot of the echoes of those issues, where now there are penalties in place where hospitals are not making it easy to share data. There are penalties in place, but healthcare is so many different small little kingdoms and different centers and different personalities and different institutions. You don't have great conformance. I think I was seeing recently, I think 70% of healthcare transactions that will take place in terms of one data to another, in terms of one person has a data file to another person, is still happening on fax. 70% still on fax, which is insane, right? So I mean, I think that it's one of the only industries where you'll see fax used so often as the main technology platform to transmit data.
So reconcile that for us, Gautam. Your stat, I believe it was 2014, that 95% is digitized, correct?
Right.
So do you have the stat for, you said 14, so 10 years later, what do you think that is? Are we 98?
Right? It's still roughly around like that 95, 97%. Like I think you sort of hit a plateau around 2014, and it sort of stayed around that level.
Well, faxing though, that can't compute as far as being interoperable at all, right? I mean, what do you do with that? You have to scan it, or it's not workable.
But it's still a network, right? It was a network. It was a system network that was set up. Someone had to have a fax and to be able to receive. For the technology to work, someone had to,
Right. But what do you do with it once you get it? To make it
optimistic, right? Because then they had to rely that other people had it. Actually, when I first started in business in the late 80s, my first job, I remember one of the owners kind of ranting. He was older about, I don't know. They didn't have a fax machine. They were like right on the cusp of buying a fax machine, and they weren't sure if they were going to do it. They were waiting for their largest client to, have call up and say, I want to send a fax, type thing. So kind of funny. It's a whole little interesting history on technology, right? But so then I guess what we need is we have to have a cloud, right? That everybody agrees to participate in. Does that exist today?
Yeah, I mean, you do have the cloud. I mean, but you sort of have the first issue of like, yes, now we digitize everyone. You got to make it a standard data format, right? It's not like, it's the same issue where, I remember I'm on a Mac right now. And I remember I switched from a Windows to a Mac, and nothing worked, right? Nothing was interoperable, right? Like the files didn't work, the software didn't work, and
by design.
By design, exactly, right? But like that was the issue. And then now over time, there's a bit more interoperability between Windows and Macs. You can port things over easily back and forth. And that was sort of, I think, the struggle of hospital electronic health record software a few years ago. Like, let's make the data interoperable. If Epic is saying that, hey, this is a document and this is how I'm structuring it, that should be able to be read by a Cerner system. So if I'm a doctor who's logging a note in Epic, and then if I'm a doctor in Cerner, I should be able to read that Epic note, but there has to be that data standardization. And so I think that's really now where I think we've seen a lot more standardization take place. And for us, I think we're now we're not there yet. We still, like we're talking about, we still do have a lot of facts. Facts is still one-to-one. It doesn't matter, that results that requires a human mind to read it, that's fine. But I think we're now getting to a point where there is increased interoperability, where the data structures are more standardized, where they're more homogenized. And so you can now start to see the sharing of data be an easier process.
Yeah. But to your point, Christine, that's not what you're experiencing in 2024 in Florida, right? Whereas I just recently had a personal situation too, and I had to sign the release of my records, and I left the office thinking, why can't they extract them from a common source? So you're saying this common source doesn't exist, right, Gautam?
The common source is it's a developing asset, right? Like it's not 100%. It is. You're seeing more and more hospitals start to conform to it, but yeah, it's not 100%, and so that results in issues where like you're mentioning, Christine, where like a hospital down in Florida is having trouble transmitting the data down to Mayo. So it results in a lot of challenges for sure for patients.
But not only that, because we're talking data, right? We're talking technology, but it has to go down to the granular level of the doctors and the providers, right, Christine? So I know my own situation, my family member who back in 2012 had all the issues. There were cardiologists, there were oncologists, there were radiologists, there's so many ologists, and they have to speak to each other and then speak to the actual patient and family members to make that whole interoperability work too, right? I mean, there's a human component to it as well, just like with everything. And we talked about that the last time, right? I mean, technology is great, but it's got to be used appropriately so it's made to the advantage of the end user ultimately. I don't know. That's just my experience.
Yeah, agreed. But I guess where maybe I'm still curious here is that it sounds as if it's still a request based versus, Christine, your parent doctor should just be able to go to a central database to look up with an ID and be able to get all of the testing. I mean, basically be able to go in and research anything they want. So Gautam, is that in the Cures Act with where I guess I'm picturing that within 24 hours every medical professional is bound to upload to this this information, this test result, if you will, to this national database.
Yeah, I mean, I think this is where like regulation is still very far away from like what happens on the ground, right? Okay. And like I think the regulation is there, the laws are there, the frameworks are there, but that doesn't necessarily mean you're going to have people conforming to what they should be doing. And I think if you're regulating something like ice cream trucks, like that's okay. Like that. If you're basically making it harder for kids to get ice cream trucks, you're gonna have a lot of sad kids. But in healthcare, when the reality is so far away from regulation, you're talking about tens of millions of people, right, or more, who often aren't getting really good healthcare. And I think that's sort of the issue with what we're seeing here, that the regulation is quite clear, and I think you do have a lot of good actors and a lot of people who are trying to engage and participate. Both software vendors who are trying to make their data interoperable, hospitals who are trying to share their data. But you do also have some other actors who are not engaging in good faith, and those might be providers who are saying we don't really know how to share data, or we don't really want to share data, or software vendors that also make it really challenging because they have their own unique data types, and it doesn't conform consistently with the data formats that other software vendors might be using. They sort of have their own little ecosystem. So, I think I'm optimistic. I think the trend line is still really good. I think that you're going to have more shared data take place. I think that, I think Americans have lost a lot of their patience, quite honestly, and have had very little patience for healthcare and healthcare inefficiencies for many years. And I think there will be more movement towards meeting the regulation and that idealized threshold where data should be shared, but it's for sure not there yet.
Interesting.
So it's very clear from everything that you're saying, and just I think from all four of our experiences, professional and personal, especially with our clients, where we're working through this kind of stuff with plan members on a regular basis. The positives, the great impacts of having good real interoperability are on outcomes and cost, what I call high value, high quality, which, drives better outcomes, which is usually at lower cost because we're eliminating waste, we're getting to right care, right place, right time, et cetera. But, what can plan sponsors and us in the advisor industry, we in the advisor industry be doing to help squeeze, to help get us there, to help, to improve that trend line, if you will? Because if we're all sitting around waiting for the federal government to do this, or to put teeth around it through fines, just like with the machine readable files, price transparency, all of that stuff, it's one of those things where we can't just be sitting around twiddling our thumbs waiting for federal policy. And even if federal policy is pushing them to this, there still has to be teeth to encourage them, basically force them to be compliant. So what can we be doing through plan sponsors and us?
Yeah. And real quick, Gautam, before you answer that, I just want to interject that that's what's so great about a free market, is that companies like Milu Health can create a platform. And I really think the government's already done everything. They gave us the laws that allowed us to, right? They gave us the tools to be able to go and demand that we can get access, share that access, and then use this platform to manage and and empower us as the consumer to manage our care and to manage the expense and to know what's available in the marketplace. So I think that we probably have everything we need. Now we need companies like Milu Health to come along and create a platform where we can use it to our advantage.
Yeah, I think I agree with both those things. I mean, I think it is, it's a really good question, Christine, in terms of what can plan sponsors do, right? And I honestly think that a lot of you guys are already doing a lot of the work that's required. I mean, you guys are really pushing the envelope and trying to think about how do you create better plans that really put the patients first and making sure that they're getting great care, and they're also managing their affordability of the plan as well. And I think that in terms of how you really try to make sure you push, I think to your point, Robin, I mean, I think the free market starts to reward the really good actors. I think that at some point you can be a bad actor for a bit and you can operate in bad faith for a bit. But I think time and time again, we've seen that those bad faith actors, they got ridden out, and I think people want, especially when it's in healthcare, you want to do business with people who are really operating in good faith and operating honestly.
Yeah. And no, it's like the Consolidated Appropriations Act, right? We have we have all the transparency laws we need now. We just have to go and do it, right? And demand and just where necessary remind those that are either they don't want to play in the sandbox or they didn't realize that they were supposed to be doing something. We have that on our side now to say this is what we need, and and if you don't give it to us at the first pass, well, here's why you have to.
I was at the SIA Health Price Transparency Forum last month at the end of February in Charlotte. And one of the speakers was talking about why plan sponsors keep getting stuck in the middle. Why is it always the plan sponsor? Why does the plan sponsor have to comply with the gag clause attestation? Why is there more teeth around it for them under ERISA law with potential ERISA penalties versus the insurance carriers or the TPAs or other actors in the process? Why is it always the plan sponsors? And the answer I heard from somebody who's in DC and who's participated on the lobbying side for SIA said is that the politicians know that if they push companies to do this, especially large companies, that it will actually ultimately get done, but it's also a political strategy. So by them not pushing policy on us, they can sit back and say, we are still this free market, this capitalistic country. It doesn't get political for them when they're trying to be reelected. And then the companies are stuck having to comply. And they've said, history has proven, at least in the last few decades, that that's an incredibly effective way of getting it done. Oh, and by the way, then the plan sponsors or their employees or somebody in the supply chain, the food chain, is going to litigate, either one-offs or class action, and they're going to spend all the money to get the teeth in it to get the legal, precedences and stuff that need to be set through the court system. So I had never thought about it from that perspective, but seeing everything that we've been seeing, particularly with the CAA in the last couple of years, it makes sense to me. And that's where, we get to the point of employers engaging, like your client, Robin, using Milu and everything that they're doing with it. That's bringing the pieces together and sort of forcing this interoperability on the provider system. Because if we keep waiting for the health systems and the insurance carriers to do this, I'm going to be in the grave, before we get there. And that's a long time, by the way.
Yeah. Well, and it's the employers and the employees that have the incentive as well, right? I mean, they're the ones that have the most to gain by making sure the system is created and works for them, and it is their system. They're paying, right? They're the ones that are paying for healthcare ultimately. So it should be their system. It should work for them. They should own it.
Totally.
Yeah. So what are your predictions for the future of healthcare interoperability over the next, let's take it 3, 5, 7 decade?
I think, I think the first thing is right now we're just solving, we're solving a lot of the silly problems that exist in healthcare interoperability. So I think we're really in the early phases. We're solving the problems that, Christine, you were talking about with, about how health data is not going from hospital A to hospital B. We were talking a bit about this earlier, right? We're solving the problem of where patients sometimes get additional labs and imaging tests because the doctor can't see the result that was previously ordered from a patient because it's from a different center, which is a kind of a nuts thing to me. I was mentioning the stat before we started this on live, but it's 1 in 3 patients gets an additional lab or imaging test because the provider can't see the result from the previous test. And that's $200 billion in wastage that happens every year. So I think that's the level that we're at right now, which is just let's make the data more available. Let's solve some of the unnecessary waste that takes place and just make the system a bit more efficient. And I think that will play out, honestly, over the next 3 and 5 years. It's going to take a while. Healthcare is notorious for its inefficiencies, of course. And I think it'll take a while for the penetration of interoperability, like we were talking about beforehand, to get to a higher threshold and for people to start to really leverage that data and the data sharing system to make sure that we can minimize the efficiency. I think over the next 7 to 10 years, though, there's some really exciting things that can develop as a result of it. One of the things that we do, right? So when we get patient data, when we're actually working with the patient, we see their entire health history, right? And whenever there's a new note, we see that, and then we're able to intervene the same day, right? So you see your doctor on Monday at 10 a.m., we see that there's a new note at 10:30, that enables us to have a proactive interaction with the patient. And I think that's a really exciting new way that some of this data unlocks a whole new channel of healthcare, right? Not just as reactive, but stuff that can be proactive. And you can imagine that for happening for preventative stuff of like, hey, you're scheduled, we see this cholesterol levels have gone up, you should be scheduling this differently, or you're due for a screening exam, or you're due for something else. I think there's a lot of ways that we can actually try to see how we can build out proactive healthcare measurements based on the data that hopefully results in better patient outcomes, better adherence, and hopefully, reduce costs as well, both for the patient and for the system. So I think I'm hoping that, next 5 years, there's more penetration, there's more sharing of data, you have a decrease in inefficiencies, and then 5 years plus, we can start to see some more innovation that takes place to make sure that we're really supporting the patients and giving them proactive care.
Mm-hmm. And okay, I'm gonna like to ask you, how do you see AI in all of this? Let's talk about it. Right, it's the hottest topic right now. My kids are like, I've really embraced this ChatGPT. And by the way, Jon Stewart does a hilarious bit. It's about 15 minutes on the false promises of AI. Very, very funny. But my kids just can't believe they're in, 20 to soon to be 27. My children are. And they just cannot believe that I have embraced ChatGPT. And I kidded them that I'm going to leave their father for ChatGPT, right? But no, truly, I see where AI is going to free us up. There's also the secret lives of living, or the secret code of living, I believe it's called. I should know this off the top of my head, but Netflix has a documentary about algorithms, and there's one statement in the documentary that said, when a sample size is too large to sort in our head, that's when an algorithm takes over, right? So I think we could all agree. You look at the data on how much data has been created in the last 12 months compared to all of civilization, right? Or in the last number of years, clearly we have these huge data sets. So how do you see, Gautam, how do you see AI working into all this? And
I think AI will be hugely important and really impactful. I think at the end of the day, patients don't want to talk to an AI. They always want to talk to a human. Mm-hmm. And I think people that forget that will end up building out solutions that I think patients won't use, or more concerningly, sometimes might also cause some harm. But, I think where we see AI being really interesting is, it goes back to what I think, Liz, you were talking about with the faxing of the EHR records and all of this stuff as well. And obviously, as well as your experience, Christine, it's, the first problem, so this is where AI becomes really interesting, right? In health and patient health data, you have stacks of paper. I was just talking to one of our nurses on our team, and she remembers back in 2008, again, she was at a place that didn't have EHR data, and she had binders worth of data for every patient, and it's like patient record files, right? Wow. Now, the first way that AI impacted those faxes and those binders worth of data was OCR, right? Can you actually read the characters in that PDF? But even if you can read the characters, you got sometimes hundreds of pages of content for a patient. And if you're a doctor and you only have 10 minutes with the patient, how are you expected to go through hundreds of pages and understand the full patient history if I only have 10 minutes of interaction? So I think where AI becomes really exciting and all the new wave of LLMs, of actually understanding these large language models, I think it can really help out in summarizing the patient history for some doctors and providing some overview. Highlights, exactly. Yeah, but there's also, you got to make sure that the models are working out well, right? You don't want the LLMs, for instance, to miss something really important because it just hasn't seen the diagnosis or that write-up beforehand. But I do think that it will help out with some of the efficiency there for sure. I'm a big believer, in this idea of like AI assisted doctors, basically. like the more you can provide AI to help out, doctors, nurses, any type of provider to make their job a bit easier, I think that will be really useful and impactful. And I think that as long as you have a provider at the end of the day to QA it, just because I think, as I'm sure you've seen, Robin, when you were talking to ChatGPT, you have all these hallucinations, and they just sometimes will make stuff up. You got to make sure you have a human at the end of the day to actually review all the results and be like, does this result actually make sense? Does this square with what I know of the patient? But I'm super optimistic that, health care is one of the biggest drivers of this new boom of data, like you were mentioning, Robin, right? Like how much data is now entering into the ecosystem. And I think you do need systems, you do need AI to make sense of the data, just because it's too much now for a human mind to fully process, absorb, and make great use of.
Right. At least not at the speed of now that this world likes, right? I mean, it doesn't, align. If you think about it, everyone wants to go so fast, but without AI, it's a very long, slow process. It's the secret rules of modern living. It was a very, very good documentary. It's about algorithms. And yeah, I think that, I just see ChatGPT and AI really to just be able to leverage my time. Really. Yeah, that's how I never in a million years would think that I'm going to, take something from ChatGPT and not read it and look at it and make sure that it makes sense, like you say. But they do have this very cool function where you can upload a document and it will give you an executive summary. I mean, come on. It's kind of like, why would you spend the time doing it the old way, right? I mean, that's kind of where I come out on with AI is if, there's a tool that is going to leverage my time and make me more efficient. Yes, please.
And this is where it gets really exciting with interoperability, right? So as you actually start to have more and more patient records consolidated and have comprehensive views, and as you have these LLMs, these AI agents get better, there's real opportunities to find out new ways that you can really help out patients. I sort of say that I always analogize U.S. healthcare to plumbing, because it's just like you have so many different pipes and the pipes don't connect, and there are cracks in the pipes and patients fall through the cracks all the time, right? Mm-hmm. And I think the way that you solve that, and the example is, for instance, like we were talking about beforehand, doctor prescribes a medication for the patient that's not covered by the plan. That's a patient falling through the cracks. They're getting a really expensive medication they don't have to. Or patient doesn't pick up a medication. The doctor doesn't know it, falling through the crack. Patient, is going to the wrong or going to a specialist who really is not the right specialist for that procedure, falling through the crack. But I think the more that you have data and transparency over that healthcare journey for the patients, and as you couple that with AI, I think you start to see how that can really start to resolve some of those cracks in the healthcare system, make sure the plumbing really works and patients aren't falling through anymore. And I think that's a really exciting vision that I'm really excited about, and that I think that we're trying to hopefully do our part at Milu to try to promote and try to build out.
You mentioned Milu. If I could, Robin, Gautam, what would you say is your ideal client?
We love working with advisors who have really creative plans and have really good things in place, and a lot of opportunities where their patients have a lot of tools available to them.
Has to be self-funded, I would assume.
Typically self-funded. I think that's really where I think we can have the most impact. Sure. For self-funded plans, we get the claims that we give a 100% ROI guarantee. And, it's just easier to do that when it's a self-funded client rather than a fully insured client, because we don't want to take on the risk of the premiums going up. But, we love clients that are, just that we really just care about working with folks who want to make a difference and actually have real impact.
Do you have any sort of size parameters?
We'll really work with a whole wide variety. I think our smallest customer is is about 10 employees, and our largest is 1,000. So it's for us is really just making sure we find the right partners, both in the advisors as well as the employers, and people who see what we're trying to do, are excited by it, and want to partner with us to try to build it out.
Perfect.
Can I iterate on that? So my understanding now, historically with our self-funded plans in recent years, some of the advances were using the claim data files or pre-certs as our springboard to identifying opportunities to engage. So maybe through a pre-cert, somebody was requesting an MRI, and that data, which was maybe shared weekly, in a best case scenario daily, with a nurse concierge organization, some organization to try to help steer, to give a call to them or contact them and say, hey, I see that your doctor is requesting this MRI and they're getting it approved for the hospital outpatient imaging center. Did you know that you can go up the street to the independent imaging center and get that same MRI with the same or better level of quality, including the reading, for X instead of Y? But it was always dependent upon the claims data or the pre-cert data. Now that you have access to the EHR, that in most instances, at least in my experience where I've been looking at electronic records, that stuff is updated very quickly, usually within 30 minutes, unless it's a test result that's pending that has to go through the analysis process. That stuff is almost always posted really quickly. So if you're accessing that stuff on a real time or very quick basis, the opportunity to get that person to right care, right place, right time, right price point, when that's important to the patient as well, is a huge step up from where we've been historically with our self-funded plans.
That's totally right. I mean, I think that, we've had in the last, 10, 15 years, these amazing companies that come with really good plans and really good programs to help patients get better care. I love center of excellence programs. Patient needs a surgery, go to a great quality hospital. We'll fly you out there. We'll put you up in a hospital. We're going to make sure you're going to go to a great surgeon. You're therefore going to probably have a lower complication rate, and you're going to pay $0 out of pocket, right? Now, the problem is, how do you find the patients who need surgeries, right? And like you're saying, Christine, like if I'm using claims data, I could say that, hey, this patient already had a knee surgery. And because it's claims data, they probably had the knee surgery 2 months ago. So let me send them a notification saying, hey, if your other knee gets busted, maybe for a knee surgery. It's like, I only got 2 knees. How many knees am I
You're in the market.
So I think, it's hard to intervene at that point. And then even if you have your prior auth flow, right, saying that, hey, okay, we now see this patient needs this knee surgery. You're coming in at a point where the patient has figured out, hey, I want to go to this doctor and I want to get this procedure. And it feels kind of bad then as a patient if someone tells me, hey, actually you can't go to that doctor, you're going to have to find another doctor instead. And also, maybe here are 3 doctors, but also, you just have to start your search up again, right? That's just a very frustrating process. And that's where I think that's where we are big believers in the EHR data, because that is real time. It is, you've left your doctor's office, your primary doctor's office. You know that you have to get this procedure. Let's intervene at that point. Where you're trying to figure out, where do I go?
Yes.
I think about this. What is the cost? Like, what are the options available to me? Do I have any benefits? And if you can help the patient at that point where they're really asking the question, that's really where I think you can drive a huge amount of impact.
And then providing the options, like Christine, you said, you weren't provided with options. You could intervene at that point and say, here are some other potential possibilities for care, right?
Totally. In fact, and one of the things that we'll even just do as well is, as I think everyone here knows, I mean, even when you have to get a procedure, even just knowing that the doctor, like let's say you chose a good doctor, even knowing that you chose a good doctor is a huge relief off your back, right? And that's something that we also did. We saw patients asking us about that. And so we've now built that into our product, where if we see a patient's referred to a specialist and the specialist is good, we'll actually say, hey, by the way, you're going to a great specialist, like thumbs up, like, you already made the right decision and that doc's phenomenal, and let us know if you need anything else. But I think that providing that information at that time when the patient's really trying to figure out that decision is so important.
That's awesome.
Do you deliver the alternative that the scores aren't that good, you may want to reconsider not going to that doctor? So
we provide options, right? We're always going to provide options. It's up to the patient to choose where they should go.
I'm just talking about, I mean, all doctors are good. I'm just saying stats. Okay, let me just, you know what I mean? They're quality scores, which is a very real database.
We do provide visibility in terms of how many procedures patients do. How many procedures doctors do. And I think that's really helpful data. I was giving this example beforehand, like, we had a patient who was due for a rotator cuff surgery and was sent to a surgeon who does mainly who's a specialist in ankles. It's a different part of the body, right? And so in that instance, we can say, hey, you're welcome to go to the, no issues. This is your surgeon. This is how many procedures that surgeon you refer to has done. Here are 3 others, by the way, who are like, have done in the 90th plus percentile that are in network.
On the correct body part.
On the correct body part. They're up here, not down.
Helpful, super helpful.
Exactly. So, but, we're not going to say that, hey, you shouldn't go to that other specialist. It's up to the patient to choose wherever they want to go.
But you said you built in, can you expound a little more on that functionality that you built in? Because I know there is a quality metric database that, there's several of them. So I can't think of, I don't want to specifically name one, but have you connected in with one or more of those systems? And then is that what you're sending with your service? If somebody
we get quality data from three different sources.
Okay.
And it's all based on claims data. They see I think one of them sees 80% of the commercial claims that are produced every year. And that helps us figure out, I think the NIH, as well as folks even here in the US, have basically just said one of the best correlates for procedure success has the doctor just done a lot of the procedures, especially in surgeries or any other kind of reviews. Practice makes perfect, and so we will provide that data to patients, through our platform. So we say that, hey, Robin, you're going to go for this kind of procedure. Here are the 3 docs that are in the top 20% or the top 10% of that procedure volume in your area that are in network, and provide that to you. We also look at complication data and other bedside manner data as well. Bedside manner, we do tell to the patient. Complications, it's hard. It's a hard thing to figure out. A lot of doctors will rightly say that, hey, I just have a really complicated patient population. So we look at that to make sure that there aren't any doctors who have, surprisingly high complication rates, and that helps us, make sure we have good confidence in the doctors we're recommending. But we will help the patient be like, hey, these are docs who are really in the top 10%, 20% of that procedure.
That's awesome. Okay, yeah, that's good. That's great information. And again, real time, not, hey, let us know if your other knee, you need another
retroactive.
Exactly.
So, and I gotta amend what I had mentioned about Rochester, New York. We not only, we're going to be in totality on Monday. We have amazing health systems here. We have 2 very large health systems. We're very fortunate.
You are fortunate.
We not only have just one, we have 2 that are excellent. And, there's never, to the best of my knowledge, there's not conversation of, oh, don't go there. I mean, you truly have 2 amazing health systems in Rochester to choose from. We're very blessed here. Like, for example, when the Affordable Care Act passed and it got rid of the lifetime limits on insurance, I remember looking at it thinking, well, we don't have those in our policies, so we have, we definitely are a center of excellence here, I believe.
That's right. You're lucky. Incidentally, my dad was a 40-year practicing physician. He always said, practice makes habit. So hopefully they're practicing the procedure correctly, right?
Good point.
All right. Well, we are
great.
I'm sorry, what?
I think this has been a great conversation.
Yeah.
Very thought-provoking.
Yes, thank you. Well, and obviously, like everything else we talk about, this is just the beginning, right? I think we are in some very exciting times where, power is shifting from the classes to the masses. I know I always beat that drum, but I am very excited about it because I know that the employer and the employee not only has the resources because they're the true payers of healthcare. With the right tools, they can get this right and they can solve it for themselves. So Gautam, thank you so much for joining us. And again, I just give I just want anyone listening or on this podcast, highly recommend you give Milu Health a look. I'm glad I did because I know my client's very, very happy with your services, and I can't wait to plug you into more. Okay. Well, with that, it's 3:00. Thank you so much, everyone. Thank you again, Gautam. And we'll see you next month on the 2nd of May. All right.
Good.
Okay.
Thank you.
All right. Thanks, everyone. Thank
Bye.
you. Bye-bye. Have a good one.